Excited to talk about updates in our clinical understanding of SETBP1 haplionsufficiency disorder. So just to get started, some very, very brief introduction. As you know, SETBP1 encodes a protein called SET binding protein 1. Basically, one of the functions of this gene is to help control the expression in multiple other genes that play an important role in brain development as well as development of other organ systems. In humans, pathogenic variants in SETBP1 are thought to underlie two different types of clinical presentations. Gain of function misspellings in this gene are thought to contribute to a very severe phenotype called Schinzel-Gideon syndrome, which is characterized by severe to profound intellectual disability, really difficult to control seizures, a lot of systemic and organ malformations and other challenges. In contrast, loss of function misspellings in SETBP1 are thought to underlie SETBP1 haplionsufficiency disorder, which is, relatively speaking, a milder version in terms of less severe cognitive presentation and less severe challenges overall. For the purpose of this talk, we'll focus on SETBP1 haplionsufficiency disorder. Some of the very early studies looking at SETBP1 haplionsufficiency disorder came up with a pretty simple, pretty basic phenotype or clinical presentation of SETBP1-HD. Some of these early studies describe this in association with intellectual disability, expressive language disorder, behavioral issues, as well as mild dysmorphisms or certain distinct facial features. These studies were based on some chromosomal studies, and as you can tell, this is a pretty simple, pretty basic understanding of the disorder. Of course, there have been a growing number of individuals who are diagnosed or who receive a diagnosis of SETBP1-HD due in part to the rising demand and rising use of whole exome sequencing, which is a type of molecular sequencing technique where we look at all 20 to 30,000 genes to see, is there a misspelling in one of these genes that explains the child's or individual's presentation. So with that said, even though there have been a growing number of cases of individuals receiving a diagnosis of SETBP1 haplionsufficiency disorder, the data about the full clinical spectrum of these individuals has been pretty limited, at least up until this point. So just last year or so, I was really privileged and lucky to be part of a study that looked at a more nuanced, a broader delineation of the clinical spectrum of SETBP1 haplionsufficiency disorder. So this was a study that was led by Dr. Van Bon in the Netherlands, who is a clinical geneticist, and Dr. Angela Morgan, who you heard from today, who's a speech and language pathologist in Australia. This was a study that looked at 34 individuals with SETBP1 haplionsufficiency disorder, 10 individuals who were previously reported in the literature, along with 24 individuals who had not yet been reported in the published literature. So I'm going to go through the features of these individuals to delineate the spectrum of presentation seen by individuals who have this condition. So in this study, there were 19 males and 15 females. There was a wide age range in terms of the individuals in this cohort, ranging from 1 all the way to 73 years of age. This is a graph that just shows the different types of misspellings that were covered by these 34 individuals. Basically, the takeaway point is that misspellings were seen across the entire SETBP1 gene. There's a large number of so-called nonsense mutations or nonsense variants and frameshift variants, which we don't have to go into the technical details, but there are certain types of misspellings that were seen in these individuals in this research cohort. This is a slide that talks about overview of some of the growth parameters of these individuals. The main takeaway point is that in general, growth issues were not a major concern in terms of weight, in terms of height, and in terms of head circumference. Of course, there can be exceptions. There are some individuals who fall outside of the norm of these different parameters. So if you have a child who's affected or individual who's affected who may be microcephalic, meaning have a small head size, or may be short on the short side or underweight, it doesn't mean that it's not part of the spectrum. I think this slide just shows, kind of generally speaking, for the cohort, what were the major trends in terms of growth parameters. We also looked at developmental milestones, including motor development and including language development. Generally speaking, there were delays across both of these domains, consistent with global developmental delay. The average age of sitting was 9 months. The average age of crawling was 12 months. The average age of walking was close to 20 months. From a language standpoint, children were delayed in their language, with the average age of first words being close to 2 years of age, and the average age of first sentences being close to 5 years of age. This is a slide that talks about the prevalence of intellectual disability in our cohort and intellectual disability severity. Just as a reminder, intellectual disability is defined as having a full-scale IQ below 70, along with impaired adaptive or self-help skills like feeding, using utensils, toilet training, and so forth. What you can see here is, I think, first of all, that there was about 17% of the individuals who did not have intellectual disability, meaning that they had IQs in the average, in the typical range. There were about 7% of the individuals who had a borderline ID, meaning an IQ that may be low 70s, high 70s, low 80s, somewhere in that ballpark. In terms of intellectual disability, there's about 30% who had mild intellectual disability, which is defined as having an IQ between 55 to 70. There was about 27% of the cohort who had moderate intellectual disability, which is defined as having an IQ between 35 to 50. There's about 20% of the cohort who had severe intellectual disability, which is defined as having an IQ between 20 to 35. I think a key takeaway point of this slide is that, number one, there is a pretty wide spectrum in terms of intellectual disability severity in SETBP1 haplionsufficiency disorder. I think another key takeaway point is that there can be normal intellect, there can be, cognition that is not in the ID range, which I think is an important concept to emphasize. A third key concept is that even among those who have intellectual disability, there's perhaps a tendency to be more on the milder side. So overall, I would say that in general, SETBP1 haplionsufficiency disorder is characterized by intellectual disability, but it may be more on the mild to moderate side versus the severe side. And normal IQ can be possible with this condition. This slide covers different types of behavioral concerns noted by the individuals in this cohort. The vast majority, of the highest percentage among different behavioral concerns, the most striking concern was a concern for attention deficit hyperactivity disorder, or ADHD, or ADHD-like concerns. So concerns about hyperactivity, concerns about focusing. So attention or concentration deficits were seen in about 59% of the cohort. Autism was not a common diagnosis, so autism was seen only in about 12% of cases. It doesn't mean that, I think some families will report that their child may have autistic features or some social communication challenges or socialization. In some cases, socialization can be a relative strength, but there can be repetitive restrictive behaviors as a more striking component. Anxiety was reported in about 24%. Aggression was reported in about 20%, and a small percentage reported self-injurious behaviors. Among neurological concerns, the vast majority reported hypotonia or low muscle tone. So this was reported in more than half of the cohort. Seizures were not really a huge concern. About 21% reported a history of seizures, but many of these a lot of these instances were concerns about febrile seizures. Sleep problems were reported in about 12% of the cases. MRI findings, not every child or individual had an MRI. Among those who did undergo MRI, the vast majority didn't show any major structural abnormalities, didn't show any major issues. There are 2 individuals who had concerns about myelination delay on their MRI. But again, generally speaking, MRI abnormalities are not a common occurrence, at least in our data. This slide goes through different systemic concerns. So vision issues, as Dr. Chung and others have reported, are a relatively common occurrence. So this can include things like strabismus, which is misalignment of the eyes. It can include things like myopia or vision impairment and some other ophthalmologic or eye-related issues. Hearing issues were not super common, so about 9%. About a quarter reported recurrent ear infections. About close to 20% reported sensitive skin or eczema. And then about 15% reported allergies to gluten, soy, or milk. This slide goes through different types of structural abnormalities in different organ systems. A key point is, so I've listed the specific congenital anomalies that were reported among these individuals. Ankyloglossia or tongue tie was seen in 5 individuals, and then undescended testes was seen in 3 individuals. I've listed also some of the other congenital anomalies that were reported by 1 individual in the cohort. The main takeaway point is that, generally speaking, structural abnormalities in different organs are not a common occurrence for SETBP1-HD. There are, of course, some exceptions, which we've listed here, but for the most part, this is not a common challenge or issue. So let's summarize the takeaway points. So first of all, I would say in general, growth is not too impacted. Second point is that the early developmental trajectory is characterized by what we would consider global developmental delay, meaning delays in multiple developmental domains, including motor skills, including language and other domains. There is a spectrum of intellectual disability that probably is skewed a little bit towards the mild to moderate versus the severe side of the spectrum. With that said, there are individuals with SETBP1-HD who do not have intellectual disability. Among behavioral challenges, ADHD or attentional hyperactivity issues are a relatively common occurrence. Among neurological findings, hypotonia is probably the most common occurrence. Among systemic issues or vision issues or eye ophthalmological issues, eye-related issues were relatively common. So I think that alludes to the fact that if it might be good to have a baseline surveillance with an ophthalmologist if you have this diagnosis. And then the last takeaway point is that structural abnormalities, meaning defects in different organ systems, meaning like missing kidneys or having heart defects or those kind of things, were not a common occurrence or something to worry significantly about. So I think, the last slide here is, where do we go from here? So I think we've talked about an overview of all the different salient clinical features that are possible or that can be seen in SETBP1-HD. I think we need to continue to look at quantitative assessments of the neurobehavioral profile of this condition, including natural history study data using assessments, including the Simons data and other quantitative measures. I think we need to continue to look at biomarkers, basically neurophysiological markers of disease severity, things like EEG, MRI, auditory evoked potentials, and other neurophysiological biomarkers, and see how they correlate with disease severity. Can they be predictive of outcomes? And I think finally, we need to identify other factors that can help predict disease severity or can help predict why some individuals may be less severely affected versus other individuals who may be more severely affected. And this can be in the form of looking at epigenetic factors. And for example, we're doing a methylation study in this condition, but other sort of factors, metabolomics, proteomics, and so forth, to see what are additional factors that may confer one trajectory for one individual and a different trajectory for another individual. Lastly, just to acknowledge my team, my mentors, Dr. Mustafa Sahin, Dr. Ampadori, my primary mentors at Boston Children's, the Radbound team, Dr. Van Bon, Dr. Angela Morgan from the Murdoch Children's Research Institute, Simons Foundation, of course, the SETBP1 Society, including in particular Haley and Elisa Mo, who's here with me as well to help with our study today. And of course, I think it remains the most important entity here to thank is, of course, the families, to you guys. I think I learned so much from talking to the families. It's a privilege for me to be able to learn more information from each and every one of you. And I'm just very delighted and just enthused by all the enthusiasm in this audience. So thank you.